Mort, thank you again for all your work. I think it's been your drive and personal initiative that's really kept things moving forward. And I'm just going to share with you some of the newest changes over the past 2 years that we've seen, some of the newest science in coronary calcium, and some of the newest guidelines that are really, I think, starting to finally bring this into the mainstream after many years of background work. So this is the definitive guideline for how to screen patients in the United States. Guidelines are the highest level of statements that we have. There's nothing higher than a guideline. So this is an ACC/AHA guideline for assessment of cardiovascular risk in asymptomatic adults. So you make it into the guideline as a strong recommendation, and that should hopefully drive both reimbursement and utilization. So we were very happy to see calcium scoring being moved up to a 2A recommendation. So class 1 recommendations in this guideline were only family history ascertainment, find out if they smoke, and do a Framingham risk assessment. That's class 1. Everything else is 2A, 2B, or 3. 3 obviously is not indicated based on the evidence, and there was quite a few class 3 recommendations. Even some of the biomarkers ended up at class 3 recommendations. So calcium scoring ended up at 2A. Measurement of calcium is reasonable for cardiovascular risk assessment in asymptomatic adults at intermediate risk. It also got a slightly weaker recommendation, a 2B recommendation for patients at low to intermediate risk because of the treatment gap that Mort so nicely described from that paper showing the patients who are appropriated at low risk who then next day have a heart attack. And finally, interestingly, patients with diabetes over age 40, measurement of coronary calcium is reasonable. And I think we're going to see more and more movement on the concept that diabetics are not all high risk, that this idea that they all deserve secondary prevention is not correct. And we're going to move away from that, I think, in most of the guidelines and most of the treatment algorithms. So then it becomes more important to figure out which of these diabetics do deserve aggressive therapy. 2 years later, the Europeans came out with their guidelines on cardiovascular prevention. This just came out, and they also gave calcium scoring a 2A recommendation. Computed tomography for coronary calcium should be considered for cardiovascular risk assessment in asymptomatic adults at moderate risk. So we have parallel recommendations both across the pond and here that are both strong. I think 2A recommendations are excellent, and I think really to move up to a class 1 indication we would need a SHAPE study that Harvey's going to describe later to show that if you get a calcium score you live longer than if you don't. And of course there's a potential treatment issue there. We've also seen over the past few months papers coming out doing direct comparisons between screening modalities. So MESA, one of the studies that have done everything to the patients. They've done, you can see here, they've done Framingham risk, coronary calcium, carotid IMT, brachial flow mediated dilation, so FMD, CRP, family history assessment, ankle brachial index. They've gone further and done MRI and a lot of blood tests, including genetic testing. The only thing that stands out, that moves the area into the curve significantly, was coronary calcium. Everything else is grouped together. So we see, for cardiovascular disease, a lot of overlapping lines with family history, and then we see one line way out here, and that's calcium scoring. So this paper definitively said, this was just 2 months ago in JAMA, definitively said that calcium scoring was the only marker in the MESA trial. 7,000 patients followed prospectively. This is over 7-year follow-up now. That calcium score is the only test that really improved risk prediction in the overall population. So that was nice. There's another study that just came out a couple weeks ago in JACC. This is Framingham risk. So this is the area under the curve for Framingham risk. This is calcium scoring, and interestingly, this is CT angiography. So there'll be some debates over the next few years as to whether CT angiography adds more predictive power. I think Jagged and others have done tremendous work identifying the vulnerable plaque on CT, and I think we're going to maybe be able to use the data from CT angiography as supplemental to calcium scoring. This is CTA plus calcium score plus risk factors. This is calcium scoring. So calcium scoring saw a big move in the right direction. CT angiography identified even more patients. And again, it's how you interpret that, and we still are working on algorithms, but it looks like there may be additive value to going beyond a calcium score even someday. But we'll stick to the calcium score for the moment. So this is a paper that came out literally about a week ago. From New England Journal of Medicine, they talked about all of the data with C-reactive protein and fibrinogen. And I think this is really critical to understand what these tests do. So in this model, 95,000 patients, conventional risk factors plus C-reactive protein improved the model by 0.0035. So if you number needed to test, right, NNT, if you test 1,000 patients, you will reclassify 3 of them, 3 people out of 1,000. Probably not cost effective by any algorithm you can imagine. If the test were $1, you'd still be spending $1,000 just to reclassify, and we know it costs a little more than that. Fibrinogen did worse, 0.0022, so you'd have to, for every 1,000 people, you'd reclassify 2. And if you combine them, you get up to 4 per 1,000. So the net reclassification is less than 1%. It's 0.3%. Tiny numbers, tiny numbers. When you look at MESA, it did even worse. In the MESA trial, CRP added no clinical value. The p-value was 0.73, and it had no reclassification whatsoever. And C-react and calcium scoring incrementally going up brings the number needed to test down to as low as 19 people. So instead of testing 1,000 people to find 3 or 300 to find 1, we can test 19 people and reclassify them properly to identify a patient who's going to have a major cardiovascular event. Or test 24 people and have 1 of them not suffer or identify properly the coronary heart disease event. So the numbers needed to test are much, much better with CT. This is just another way of looking at it, basically the same data, but we identify calcium scores. The increasing score, the more likely those patients are to have an event. So low scores, low event rate, intermediate scores, low event rates, but a little bit higher, and high scores, a very significant event rate. So we can see the concept that we're moving in the right direction and identifying patients properly and being able to stratify risk. Now, something that I think we're going to see a lot more of, there's something like 18 million lung scans done in the United States every year for lung cancer detection or for evaluation of lung disease, and the calcification that can be seen on these studies. So we can't quantify it quite as accurately as an Agatston score or a volume score that we get from a gated calcium score, but a non-contrast CT of the lung does show us calcification. And this was a paper from a lung cancer study, the LCAP study from New York, and they showed that those patients who had coronary calcium, had significant coronary calcium, were more than twice as likely to die of cardiovascular disease. So we have even a simpler way maybe of screening that we can extend beyond the very simple having to get everyone through a calcium score and try to get people in even for lung scans, and now we can potentially, if you will, identify the number 1 and the number 2 cause of death with 1 scan. We need more work with this, and there's a lot more coming out, but the concept that we maybe can get away with some variation and a non-gated study to at least identify those people with a lot of calcium is fruitful. So we talked a little bit about reclassification. The net reclassification for CRP is about 1.5%. So not great, but it does a little bit. This is from the Heinz-Nixdorf recall study. This was the original presentation from Jack, and you can see reclassifying into this is the intermediate risk category. We move upward Some percentage of patients we up-classify, so we thought they were intermediate risk by risk factors, and we find out that they're actually high risk. Conversely, and this is really important when we get into cost, the vast majority of patients are downwardly classified. So what we thought was an intermediate risk person had no coronary calcium. And this is really an important concept. Half of the American population, at least based on MESA, have scores of 0. Okay, that's 45 to 85, that's Hispanics, African Americans, Asians, Caucasians, 50% men, 50% women. Half of the population have scores of 0. So it's not that everybody has coronary calcium and therefore everybody needs aggressive therapy. The great part about SHAPE is that we're going to be not only up-titrate or up-classify patients and find out patients who really do need therapy, but we're going to find a lot of patients who maybe we can go without a statin for a few years or without further cardiac testing for a few years. And there might be some huge cost savings in that population, and I'll show you some data from Dan's group in that regard. Another paper that had a very impressive reclassification was the Rotterdam Heart. So 52% reclassification. For every 2 people you scan, one of them is moved upward or downward if they're intermediate risk. So we're moving half the population to a more accurate representation of their coronaries. These numbers vary between about 30% and 70%, but scanning 2 people to reclassify a patient. Huge benefit in these studies. This is just unheard of numbers. Remember, the comparable number in this study was 0 for CRP. It didn't even work, but it was 1.5% in the big meta-analysis. This is 52%. So 40-fold improvement over C-reactive protein. Rotterdam also, like MESA, looked at comparative benefits. So the Rotterdam Heart Study looked at comparative. Which test is best at identifying risk for future cardiovascular events, published in Annals, and by far, coronary calcium stands out. It is significantly better. There are other things that predict events, certainly. Carotid IMT we're going to hear more about. Pro-BNP, interestingly, I think of that as a heart failure drug, but it predicts heart failure test, but it predicts cardiovascular events. And even things like fibrinogen and leukocyte count, white count outperforms C-reactive protein and homocysteine, tests that we've commonly used. So we have another comparative study, prospective study, looking at the relative benefits of the test, showing us that calcium score, plaque in the heart, is showing us who's at risk of a heart attack, right? The heart of the matter. In the Rotterdam study, because I think they were older patients, it even predicted heart failure. Very impressive. 4-fold increased risk of heart failure if your calcium score is elevated, and the net reclassification was 34%. 34%. 1 out of 3 heart failure patients got reclassified. So you look at 3 people, and one of them you're going to say is really high risk for heart failure and not low risk for heart failure. Stratification was dramatic. Calcium scores above 400, high levels of heart failure. Calcium scores of 0, low levels of heart failure. This didn't work as well in MESA or in the Heinz-Nixdorf recall study because I think they were younger populations, and you get dilated cardiomyopathies where obviously the calcium score should be 0. So then we come to the proof, right? So this is Dan's study. Dr. Berman did this here, the Eisner randomized control trial. The proof that if we scan people, they're going to do better. And there was 2,000 patients randomized, scan versus no scan, and they got the calcium score on top of risk factor consultation, so they got additional information or not. Half the people did not. And there was improvements in treatment. There was a reduction in their Framingham risk score. There was a reduction in their waist size. More importantly, I think the doctors acted appropriately on the calcium score results. So patients with a high calcium score had a much bigger movement in their LDL, in their blood pressure, in their exercise over 4 years. This is 4-year follow-up. This is very impressive numbers. New lipid therapy was started 65% of the time. New blood pressure almost 50% of the time. Aspirin 20%, and lipid adherence. Very significant. Compliance goes up. Part of the whole basis of that SHAPE study that we're potentially doing with the NIH is that if the patients get a calcium score, they're going to remain more compliant than if they don't get a calcium score. And this was shown in this trial. So those patients who were shown calcium 4 years later were still taking a statin. Very impressive. And already a very good population, but very impressive. But most importantly, Mort said there would not be short-term cost savings. There may be short-term cost savings with a calcium score. So this is data from Dr. Rosansky and Dr. Shaw, published in JACC last year. And it shows if you compare the costs of the patients who got a scan to those who had a 0 score, this is just compared to who didn't get a scan to the zeros, right, which was a majority of the patients, there was actually cost savings. Even if you incorporate the cost of the scan, you save money. So the scan is built in, and they still went, because they had a 0 score, for less procedures and less medications. And got less medications. So there was actually cost savings for those with 0. Now there wasn't cost savings for those with a positive score, but the net was neutral. So there was no cost increase over 4 years by adding a calcium score to this population. So if we value any of these interventions, better blood pressure, better LDL control, more exercise, more lipid therapy, more blood pressure therapy, better compliance or aspirin use, then a free calcium score, net 0 calcium score to the population is something that we should probably strive for. And again, no overall costs added, more money spent on those with a high score, but cost savings with a 0 score. Very important to understand, short term. The last guideline I wanted to show you is from the United Kingdom. This is in a symptomatic population, symptomatic population, but they are now advocating and doing in the UK. If you come in with a low probability, 10 to 30% probability of coronary disease, you have chest pain of some sort, they start with a calcium score. If the calcium score is 0, they move on to other causes of chest pain. And this is being done. Score 0, investigate other causes of chest pain. Calcium score positive, go on for a CT angiography. So we have now national guidelines, at least in the UK, that are incorporating this in an upfront manner, and these are well adhered to in the United Kingdom. So I want to just end with one of I think the people who had a lot of vision in this field, Scott Grundy. Scott was involved in NCEP 1, 2, 3, and 3 update for the National Cholesterol Education Panel, and the first author of most of those. And he really has been an advocate of calcium scoring, or at least atherosclerosis imaging. This is from his paper in 2008. It individualized risk assessment beyond the use of age, which is a less reliable surrogate for atherosclerosis burden. So he kind of invented the concept of vascular age, that instead of saying you've been on this planet for 62 years, therefore your arteries are 62 years old and you may be at increased risk, we measure the plaque in your coronary arteries, and if your coronary arteries have no calcium, then your arteries are 40 years old and not 62, and we plug that into the model. If you have a lot of coronary calcium and you have the coronaries of an 80-year-old, then we plug 80-year-old coronaries into the model, and it's a much more accurate representation. It's an integrated assessment of lifetime exposure to risk factors, so it's cumulative data, not what's going on today, right? That's why it doesn't, CRP and calcium scoring don't correlate that well, because CRP is what's happening this moment, not what's happening over time. And it identifies individuals who are susceptible for atherosclerosis beyond established risk factors. So we can go beyond the standard 6 risk factors or the 12 risk factors that we may try to incorporate and see what's really happening to the coronaries. And obviously sometimes patients have a lot of risk factors and 0 scores. So he just ended with, once subclinical atherosclerosis is detected, intensity of drug therapy could be adjusted for plaque burden. In other words, simple algorithm shaped guidelines basically. The more plaque you find, the more aggressive you get. And I think that's really an important but very simple concept that he laid out for us, and it's been something that Mort's been proposing since 2003, and I think now we're starting to see it in a lot of the guidelines. So I'll just leave you with this, as Mort already described, heart disease is too often sudden cardiac death, and we need a way of screening. We need a way of identifying them before the cardinal event. We don't want to find them down. As cardiologists, we often don't see the sudden death. So we under-recognize the problem because we see the survivors of MIs. We don't see all the people who didn't make it, who died in the emergency room or never made it to an emergency room. But there are a lot of them out there. So I think we can do a better job. Thank you all very much.